No, that's Hello and welcome to this webinar, which has the title, The Role of Occupational Therapy in Tic Disorders. My name is Dr. Shonet Anderson and I'm a research psychologist, and I'm joined today by Emily Scholas, who is an occupational therapist from the US. And we're delighted to give you this webinar today and make it accessible online so that people can hear more about why occupational therapists can and perhaps should get involved in delivering behavioural therapy for tic disorders. So we're going to go through, I'm going to do some slides and then Emily's going to do some slides. So if we can go to the next slide, that would be great. Thanks, Emily. So this webinar today is part of a series of seminars being run by the Behavioural Therapy for Tics Institute, or BTTI, which offers online webinars and training for healthcare professionals about behavioural therapy for tics. The BTTI offers a range of different events, such as training in how to deliver behavioural therapy, in masterclasses, which are like a deep dive into a particular subject around behavioural therapy for tics, and also clinical consultation sessions. So that's where people come along and they get sort of peer support from other professionals who are using behavioural therapy for tics. We realise that often supervision locally can be quite difficult to get hold of. So we hope that these clinical consultation sessions help people feel confident and actually delivering the therapy, especially when cases come along that might be challenging or they have questions, etc. So we're really delighted to offer this webinar really as a kind of introduction to behavioural therapy for occupational therapists. So it's not a training in itself so much, but it's all the reasons, all the sort of understanding about what behavioural therapy is and why occupational therapists can be involved in that. And we know absolutely that there's a real shortage of people in Europe and in the UK who are trained in delivering behavioural therapy for tics, and patients and their families really would like to be offered behavioural therapy where possible. Next slide, please. So today's webinar is covering a whole different array of topics, such as the history of tics and Tourette Syndrome, treatment options for patients with tics, differences in tic diagnoses, some of the characteristics and statistics of patients with tics and tic disorders, the neurological processes of tic disorders, comorbidities, which we know are often an issue coming along with tics. It's very seldom that tics come along on their own. And then looking at what tic disorders are compared to other movement disorders, and factors that might affect tic expression and tic frequency, and then various treatment options as well, and then the behavioural basis of treatment with behavioural therapy in tic disorders. And then looking at the OT's role in how they can support patients with tics and tic disorders, and the other resources that we can share with patients to support them and help them on their journey sort of through diagnosis and beyond. Next slide, please. So first of all, the history is, you know, where did this name come from? It came from a French neurologist in the 1800s called Georges Gilles de la Tourette, and he worked in Paris under a famous a doctor called Charcot, and he described patients characterized by involuntary movements, echolalia, coprolalia, and uncontrollable sounds. And for those who don't know, echolalia is the repetition of speech, echopraxia is the repetition of gestures, and coprolalia is the utterance of swear words, etc., and uncontrollable sounds. So these were the first sort of notes that he took around patients that he was seeing with tics. Next slide, please. So there are, one of the things I always say in my webinars is there are many more tics around than we might first imagine. I think we always think about Tourette syndrome being rare, but actually tics in themselves are very common. And there are different types of diagnoses that we can give to a patient. They can be provisional or transient tic disorders where they come and go. There can be persistent chronic tic disorders which hang around for much longer. And then there can be disorders such as Tourette syndrome. And all of these different types of diagnoses have different classifications. With Tourette syndrome, the onset must be before 18 years of age, and they have to have been both motor and vocal tics for more than a year. And then there are other disorders which have tics associated with them as well. Next slide, please. So there's some facts and figures straight away, that there are typical ages that tics appear. There's a general course and diagnosis. Again, these are generalizations, but it's been found sort of to be the case that boys, for example, have a 4 to 5 times greater frequency than girls of having Tourette syndrome. That motor tics usually present before vocal tics, and often it's in the head and neck area with blinking and sniffing being some of the most common ones that appear first. And there's the role of hereditary, so that these are genetic in nature. This is an involuntary neurological condition, and that the ages of onset can sort of be around ages of 5 to 7. That's usually when tics start. And that it's believed that around 1 in 160 have Tourette syndrome, and 1 in 100, about 1% of the population, are diagnosed with Tourette syndrome or a tic disorder. So that's actually quite a lot of tics, and at some point in their lives, a lot of children will have tics, and they may just dissipate with time as well. It is also believed that around 50% of tics go undiagnosed too. So I think here I'm going to hand over to Emily to carry on the slides.
Sounds great. Thank you. All right, so we're going to go over some of the characteristics of tics and Tourette disorder. So this is an impulse inhibition disorder. It's neurologically based. So if you're thinking about, kind of that self-control piece, that's what a lot of these patients are missing, that self-control, that filter. And then tics can be, simple or complex. So you can have something simple like an eye blink, or you could have something more complex, which would be like a whole string of tics kind of combined together. And then you could have motor or vocal tics, meaning obviously movement or something vocalized. Also, a sniff or a throat clear would be considered vocal tics. And then you could have persistent or provisional tics. So you may have tics that are consistent throughout your life. You're always throat clearing. That might be considered persistent or chronic, or you might have some that come for a week or a day or a month, and then you never see them again. So just kind of varies. People with tics and Tourette's have a really, really high rate of comorbidities, which we're going to talk about a little bit more later on as well. And then the underlying symptom of these patients is they have this premonitory urge. So this feeling, this nasty sensation, and it's relieved when they do the tic. So that's another big factor in them doing that tic, is they have that urge, that nasty feeling. I always think of it as like an itch. If I had like a bug bite or a rash and it would just be there and eat at me, and if I could just scratch it, I would get that relief. That's what I always think of. And then tics wax and wane. So different periods when they're higher and when they're lower, they're not really going to go away because it is a neurological condition, but sometimes they'll be more obvious than others. Okay, and then, so what's happening in the brain? This is a neurological disorder. So I just wanted to mention the role of mirror neurons. So when you see people, we all kind of mimic, kind of like a yawn. If you see somebody yawn, you're not encouraged. Nobody likes yawning, right? But if I was to start yawning on here, we'd all be yawning. So that's our mirror neurons kind of firing. So the same thing kind of happens with tics and Tourette's. People sort of pick up on those little pieces of movement from other people. And then what happens here is looking at the actual structures in the brain. So the basal ganglia is kind of like that filter, where I might see somebody yawn and my body's like, nah, you're not going to yawn. And I might filter that out. But for people with Tourette's, they don't really have that. That filter is kind of misfunctioning. So that's an area where, one area where we see it. And actually, even in brain scans, people with Tourette syndrome do show abnormalities in that basal ganglia area. And then the prefrontal cortex is that motor area. So it's actually the emergency brake, kind of the override from the basal ganglia of what motor actually comes through. And it's an intentional area, so it's an awareness area. So it kind of really looks at, it just intentional stopping of things And this is the basis for a lot of the behavioral therapy in Tourette syndrome, is that conscious area, that prefrontal cortex. What can we interrupt? What can we consciously make a note of and work on? And then the striatum, so that's the neurotransmitter for dopamine, which affects movement, attention, cognition, memory, all those executive function skills that we need. And again, in people with Tourette syndrome, it's 5 to 10% smaller. So that's kind of showing that the dopamine regulator is really not working well, like doing what it should, as it does in the typical population. And then what's happening with all of this is this loop, which I always mispronounce, so I'm going to try to get it right, but it's called the striato-thalamocortical circuit, or the CSTC, which is a little bit easier. But what's happening there is this feedback loop. So they have that premonitory urge, that nasty feeling, and their body learns, oh, if I do this tic, this movement, or this vocalization, whatever it may be, that felt good. That gave me relief, because that urge, that premonitory urge, is so uncomfortable. So what happens is their body learns, those brain structures learn, that filter learns, oh, when this yucky feeling comes through again, don't filter it. Don't filter the movement. Just let it happen, because I'll feel better. So that loop just strengthens and strengthens, because the body learns, oh, it feels better when I actually do it. Even though they don't necessarily want to, they just really want to get rid of that urge. So here's some examples of different types of tics. So that some of the simple motor tics, eye blinking, eye movements, nose movements, just kind of like I talked about, just kind of one basic movement. And then some of the complex motor tics would maybe be touching things. So you might have somebody like lifting their arm, raising all the way up to touch something, a whole string of things, maybe grabbing something and throwing it, could be anything. Just more complex, like a string, like we talked about. And then the same thing for this simple vocal tics, could be something simple like a sniffle, throat clear, something like that. And then your more complex vocal tics are going to be obviously maybe syllables, words, repeating sentences. There could be so many different complex vocal tics. Okay, so looking at some of the comorbidities, there's a lot. So this iceberg is great. This is from the Tourette Association of America. It really just kind of shows that we see just a little bit on the surface, but underneath, there's usually a lot going on. You can see behavioral issues, learning disabilities, anxiety, impulsivity, sensory processing, executive function, those attention issues, just so much under the surface that we don't see that these people are going through. And sometimes they don't even know, because it's maybe normal to them. They've always dealt with it. So just good to keep in mind that a lot of your patients probably have something, some type of comorbidity. Usually it's about up to 80 to 85% that do have some type of comorbidity, comorbid condition, along with tics. And some of the common ones are OCD, anxiety, disruptive behaviors, ADHD. And then I think the thing to me that's really sticks out, I guess, is that youth with Tourette syndrome are actually 4 to 5 times more likely for suicidal ideations than any of their other peers. And that was done in a study from the Tourette Association of America and the CDC. They did an impact study in 2018 and found those results. So that's pretty appalling to keep in mind. And then this is another thing from Tourette Association of America that just kind of shows for children that are diagnosed with Tourette syndrome, 86% have at least one additional mental, behavioral, or developmental disorder, according to the CDC data and stats. So you can kind of see on here all the different ones. Some of the higher ones, 63% have ADHD, 49% with anxiety, 47% learning disorders, and then 42.6% have at least one co-occurring chronic health condition. So really high comorbid conditions in this population. And then this is just another great chart. So the red is going to be somebody with I want to make sure I say this correctly if it's just tics. Okay, so it's actually Tourette syndrome, not just tics. Somebody with Tourette syndrome. And then the blue is going to be somebody without Tourette syndrome, any of their other peers. And so you can see that the red in every single one of these categories is just off the charts in comparison to the blue. Maybe not all of them are off the charts, but the red, the children with Tourette syndrome have a higher rate of all of these conditions than any of their other peers without it. Okay. So we talked a little bit, I know Dr. Anderson talked a little in the beginning about tics versus other neurological movement-based disorders. So some can really appear a lot like tics, but they're actually really different. So it's important to make sure that as an OT, if you are seeing a patient with tics or what you think is tics, that they've gotten an accurate diagnosis from neurology, and maybe you're also working with psychology and hopefully some other disciplines as well. But definitely need to make sure you have that right diagnosis. So just to go over some of the basic differences is tics are not enjoyable. Some other movement disorders like stereotypies, people actually do enjoy them. So it's completely different. The presence of that premonitory urge that we talked about, that sensation that they want to relieve that feeds and strengthens that feedback loop, is always in tics, and it's not in other movement disorders. So that's also kind of a classic sign of if it's a tic or if it's not. And then tics are sometimes associated with pain. And with other movement disorders, they could be also, the movement could also potentially be painful. Associated with discomfort, again, similar sometimes for both, not always, of course, depending on what it is. And then associated with stress. So in tics, very frequently, stress and anxiety, the tics are usually increased. And then with other movement disorders, might not be, depending on what disorder you're looking at. So just, again, really important to speak with neuro and make sure you have that accurate diagnosis and know what you're working with. Okay, so some of the things, of course, as OTs that we can actually work on are the controllable factors. So in this list here, there's controllable and then uncontrollable factors. So of course, like I talked about before, how that dopamine regulation is happening with the striatum is a factor that affects your tics, your neuroanatomy. So the different sizes and different brain structures, like I talked about, or abnormalities in the brain are going to affect tics. Neurophysiology, so those sensory motor interactions, the inhibition control, things like that, the strength of that premonitory urge. We'll talk a little bit more too later on about differences in sensory sensations. And then I know Dr. Anderson talked about a little bit about genetics. They play a really big role. There's a lot of charts and stats and different numbers I could go into, but parents having children, if there is a strong genetic link, doesn't mean that you always will have it, but there is a strong genetic link. And then environmental factors. This is a really big one for us as OTs, something that we can actually work on. So internal and external factors. So we kind of talked about, stress increases tics very, very frequently. So if you're trying to keep the tics down, if you can, sometimes avoiding really stressful situations would be a good thing to help. And then internal factors, how are you feeling? I guess I explained that kind of opposite, sorry. Putting yourself in stressful situations where are going to be stressful, or loud, or looking at all those sensory pieces. What are those pieces that for this specific person, because it's different for everybody, affects them? So helping them to think about that and kind of manage their tics in that way. And then also internally, that stress, that anxiety, are you tired? Do you have too much energy? Those internal factors. So those are some good things as OTs we can work on, and we'll talk more about that later as well, but just to sort of touch on it here. Okay, so here's some of those factors. So those internal and external environments. So predictability. So for your internal environment, somebody might know, hey, whenever I'm stressed, my tics go through the roof. So working on things like how can we keep that stress a little bit lower? Like what can we do? Work might be stressful for some people. School might be stressful. So it's not like we can just say, oh, well, we're not going to go to school. So we're just working on managing that. What can we do as OTs to manage that? And then those external environments. So this is obviously a really busy scene, and just to be prepared, knowing like, hey, if I'm going to the mall on Black Friday, it's probably going to be really busy, and not being shocked by that, and kind of thinking about, is that a good environment for me to put myself in? It might be fine, and it might not be. So just knowing, again, about that specific person and being able to help them and know what effect that it has on them, because it is different for everybody. Okay, so some current treatment options. These are not in recommended order. These are just options that are out there. So sometimes ignoring the tics is appropriate, and we'll talk a little bit more about that later. Some psychoeducation, just letting patients, parents, families know what's going on is really helpful, giving them some of that history on genetics, on what's happening in the brain, things that they just might want to know about can just be really helpful just to get them started if they're interested, not sure if they want to do more, and even just for their own information if they don't want to do more. There are medications and pharmacology options, surgical options, behavioral-based therapies, and then deep brain stimulation. So a lot of these are still kind of in trial phase, not always recommended for pediatrics, lots of different factors. So I put stars next to the ones that I thought were appropriate for OTs to have some type of a role in. There's a plane passing, so I'm going to give that just a minute, sorry. Okay, so I just want to comment that for the medications, hold on, I'm going to let this plane pass. Sorry, I thought it was done. Okay, so for the medications, the one thing that I would say is obviously we're not prescribing medications as OTs, but I do think it's important, we see our patients so much more frequently than our in the States, we call them a primary care physician. Your general medical doctor sees them. And so it's really important to help with like noticing like, hey, this person used to be, so happy, and now they come in and they seem really depressed, or vice versa. Or, oh, they've put on a lot of weight from the medicine, or they've lost a lot of weight from the medicine, or, we can't say from, but around the same time that they did. So kind of talking with them about that, making sure that they're noticing these things. And if you have the right to speak with their physician, maybe letting them know, hey, I noticed so-and-so's lost like 30 pounds in the last month, around the same time they started the medication, whatever the case may be, just kind of making sure that you're there just to help monitor those symptoms is always really good. And again, all these things are a symptom management. Even the behavioral therapy is a management. It's never going to go away. It's a neurological condition that starts in the brain. So it's not like something we can just, it's not a physical condition that we can fix, but we can help manage it, certainly. Okay, so some of the different behavioral interventions that are out there for tics. So the really cool thing about this for the therapy world is that there are a lot of organizations, and you can see them all listed on there, that actually recommend behavioral interventions as a first line of treatment. So that's great. They have to at least consider it before medication. And it doesn't mean that behavioral options are appropriate for everybody, but it's great that we're at least thinking about that before we just put something into our bodies that has some side effects and things. So I think that's really awesome for the therapy world and for our patients. So some of the behavioral interventions that are recommended are CBIT, comprehensive behavioral intervention for tics, which is what I have my certification in, and then the exposure and response prevention, the ERP, and the habit reversal therapy, which is the HRT. And I know Dr. Anderson does a lot more with the ERP than I do. So if you have questions on that at the end, she may be the better go-to for that one. But those are all recommended first line options. Okay, so some of the behavioral interventions, this is going to be kind of brief because we're not really having a behavioral class today, but I do want to touch on it, that are recommended for tics. So we're looking at, like I said, with that brain, with that prefrontal cortex, kind of pulling that emergency brake and not letting some of those things through that are sneaking through in patients with tics and Tourette's. So you want to be creating new habits and interrupting those conscious brain processes. So that awareness area in that prefrontal cortex, that consciousness, and kind of like, helping to work with that area of the brain. That's what we're looking at doing as from a neurological or cognitive perspective. And then, of course, like we talked about earlier, making those environmental modifications. So even thinking about things, I heard somebody talk about a headbutting tic. So setting environments, for safety. If somebody does have a headbutting tic, just making sure that they're, aware of their space, kind of doing what we can in an environment to modify and make changes, things like that. If people are in a wheelchair, what's a safe position so they're not hurting themselves. Really a lot of factors to consider as far as the environment. And then also, with behavioral based treatments, if you think about the ABCs, those antecedents, behaviors, consequences. So are there certain environments where you just know those tics are always going to happen? So there's your antecedent, whatever the environment may be, the behavior is the tic, and then the consequence. Are they getting tons of extra attention from it, even if it's bad attention? Are they getting extra computer time or extra TV time or something like that, something that's almost rewarding that tic, and not that child or that person is maybe consciously doing it, but their brain is learning, oh, hey, when you have this tic, you get an extra snack after school, or you get, whatever that little reward may be. So thinking about, are we rewarding tics unintentionally? So things like that are good to think about. Okay. And then these are some of the things that we're going to go through a little bit more in-depthly, really specific OT things that we can do, just to look at what we can do for patients with tics. Even if you don't have this behavioral training, these are just really general good things to think about when you think about the brain of somebody with tics and Tourette's and, these other factors that we've discussed in the previous slides. So I talked about that, quote, doing nothing. When is doing nothing appropriate? So sometimes watching and waiting is great. If tics are just tics and they're not bothering anybody and they're not causing harm, they're not upsetting the child, or the adult, whoever it may be, it might just be okay to just watch and wait and just be mindful and just say, not right now. I was just talking today about somebody that I had consulted with, and they had said, what do I do? This parent is saying that their child has these really strong eye blink tics or eye scrunching, and, the doctor wants to put them on meds, but the parent is concerned because the meds are so strong. And I said, well, is it causing any other issues? Is she seeing anything else? The parent noticing any other way that it's bothering them? And she's like, no, they're not. And I was like, well, they might just want to wait and be aware of it. And if it's not causing any issues, they could probably just wait if they wanted to, talk to their neurologist, talk to their doctor about it. But if it's not causing any other issues, she might not need to start meds. It's a choice for them to make. But it's not always appropriate to start a big intervention if it's not causing any issues. And some patients might not want further intervention. They might like their tics. They might not be disruptive. It might bother parents. It might bother family. It might bother friends. But they just have to really consider what's best for them. And even considering just some psychoeducation, like we talked about, educating them on different topics, things like that might be appropriate versus actually doing some intervention. Okay, so the sensory system in people with tics and Tourette's. So statistically, they're really hypersensitive, primarily to tactile stuff, and then they're over-responsive. So they really enjoy that deep proprioceptive input, so really heavy crashing, that's just that strong input. If you can think of, I always relate it to P's because that's where most of my work is, but you can think of just a high impact sport, football, karate, things where you're kind of slamming, all those kind of different things they really enjoy. And they usually have a lot of difficulty with self-regulation. So that's just another thing. So as an OT, what we can think about doing is, of course, helping for skills with self-regulation, giving them a sensory diet, what's appropriate, what would help them based on their needs. Making those modifications. And then, of course, whether it be adults or pediatrics, thinking about educating others that you need to, whether it be work, families, schools, set up appropriate environments to meet those needs so that they can function to their best of abilities. And then cognitive skills in patients with Tourette's and tics. So we've talked about that it is that impulse inhibition disorder. So those that self-control piece is really tough, or that's at least what it looks like. But it's really impulse inhibition. And then having poor executive skills functioning. So all those tasks that you see on there. So the impulse inhibition, organization, planning, task initiation, all those kind of things, those higher level cognitive skills are really tough for them. But usually there is some kind of, I heard an interesting webinar on their superpower. Usually there's something really great that somebody with tics or Tourette's has that other people just don't have. They have a special skill in something. So it's really, really cool to get to know these people and kind of find out what is that special thing about them. Everybody has it, and they do too. So as far as OTs, what can we do? An assessment for executive skills would be great. Definitely something we're within our scope to work on. I know also speech therapy works on that. So something to, talk with patients about if they're wanting to participate with something like that. And really identifying what those difficulties in the functional skills are to work and address those brain areas, help them complete those tasks. So if they're always disorganized, or if they always have poor time management, things like that, maybe not working directly, but maybe indirectly on that brain area to make it a little bit more enjoyable would be something good to work on. Okay, and then education for patients with tics and Tourette's. So talking to their provider, if you have that consent with them, talking about what are their treatment options, and even considering some CAMs, so some complementary and alternative medicines. So sometimes yoga can be really stress relieving. If there's somebody that has higher anxiety levels, which increases their tics, all different things like that. Things to just talk with their provider about, and letting them know to talk with their provider about that, and or having that three-way conversation if they're comfortable with that. And then training them and talking with different places. So whether, you're teaching them to advocate for them or their children, in places of work, in schools and other settings where they're going to be, if this is going to be something that carries on, which in about a third of the patients, it actually will go away just naturally with time and age. But for the other 2/3, some it will decrease, and then 1/3 it will carry on just as it was. So if these people are going to have a job as they get older, they probably will have to start advocating for themselves. So rather than just doing it for them, teaching them, training them how to do that is really important so that they can be successful in life. And again, if you do need to provide education to schools and other settings, letting them know statistics on different things that they may have questions on, giving them general knowledge. And then, of course, resources, giving them, websites, online community support groups, just whatever they may need. There's so much out there, but helping them hook up to that is really important. And then here's some of the CAMs that I just mentioned that may be helpful depending on who they are and what their needs are. So just things to think about. Definitely, speak with their doctor on it. I heard the supplements are on here. I heard a really interesting webinar one time years ago about vitamin E. And I don't know if there's more research on this or if there was any validity to this, but it was from a doctor. And she was saying how she had this parent that was giving their child vitamin E and she thought it was helping. And it turns out there was all this research on how it was increasing tics. And she's like, I told them to cut it off and, no more vitamin E. So that was a few years ago. I don't know if that's how the research has panned out since, but sometimes those over-the-counter herbal supplements that we think, oh, this is really relaxing. It may be for some people, but everybody's bodies are a little bit different. And so just really important to keep even those little things in mind that you think are safe because they're over the counter. Just touch base with your doctor and make sure that that is really the case. Okay, so then medication for these patients that for tics or Tourette's, there are really a lot of side effects with these. So just kind of, as far as OT's role and what we can do, med management is a great task, especially if they're adolescent age or adults. Really, really good task for them. And some parents may even need it. So maybe even parent caregiver education and med management will be really important. So we're not overdosing or underdosing. And then staying up to date, make sure that that we talk with our patients about what meds they're taking and how they're feeling regularly, because we see them regularly, to help them monitor side effects and stay in touch with team members, for safety purposes, because, some of these side effects are very strong and not everybody's going to have every one of these, but just keeping that in mind and helping them stay aware of what's going on in their body. And then again, encouraging them to talk with their physicians, about their concerns with the medication. What effect is it having on them? Is it helping? Is it not? Things like that. So this is a really great chart that I absolutely love from the Tourette Association of America. And it kind of shows, at least in the therapy world, so many things that OT, PT, and speech can do. So you might get a patient that you think, oh, I'm going to work on this behavioral thing or that, but think about, what other disciplines can really help. And honestly, speech can do so much, PT can do so much. And there's just so many other team members, different disciplines that we can get involved. So psychology, we talked about that rate of suicide being so high in youth. So really making sure that that you're talking to them or parents about, getting psychology involved. Again, making sure we have that accurate diagnosis that it truly is tics and it's not something else, and getting neurology involved in making sure that's correct. I think you guys call it physiotherapy. We call it physical therapy. But, pain management's a great one for physical therapies. People that have, especially I feel like that that cervical pain, really with people with head jerk tics, it just gets so painful back there. So PT can really be a great one for some of that pain management without medication is nice. Speech therapy for those executive functions or social skills, it could be embarrassing. Even if other kids aren't necessarily noticing it, especially if they're young, they may feel embarrassed. They may feel like everybody's looking at them, and just healthy ways to talk about it. If it's going to be a part of who they are, how do they talk about it with their friends? It's going to come up probably at some point. So just helping them to know, like, hey, you can be confident in this, and here's a good way to talk about that. Speech is great for all those social skills. And then, of course, behavior therapy to work on some of those behavioral things that we talked about. And often even there is just behavioral concerns or issues as a comorbid condition. So even if you're not working directly on the tics, some of those comorbid conditions can be great for behavior therapy as well for a referral. Oops. Does anybody know, I didn't see my slide at the end there, my comment. Does anybody on here, I know we only have two, does anybody know what paleographia is? Has anybody heard of this before?
I haven't heard of it, but I would say with the graphia, that's going to be the writing side of things. Yeah.
Yep. So paleographia kind of looks like this. I don't know how well you can see it up here, but on the first picture, if you look, a little bit starts on line 1, and then it really kind of picks up more as you go. It's that writing and rewriting over certain words or letters, numbers, different things. And a lot of kids or people will just say, oh, making sure it looked, just right. Like it just didn't look just right. And really there may be nothing wrong with it. And there can be an OCD piece to it too, maybe. But this is something because as OTs, we're doing so much with handwriting and things to really keep an eye on that this actually is a tic. And even if you're not going to necessarily address the writing piece of it, but then thinking, oh, this patient has a little bit of a different brain. Now let me look at their executive skills. Let me look at what other things might be going on with them. How else can I help them? It kind of opens up a whole new can of worms, even if you're not directly addressing this paleographia, but that's what it is. And we do see it a lot as OTs. And then again, functional skills, any ADLs for us are huge. And during the time that they're going through those wax and wane periods, so when it's stronger, when they're going through those wax periods, so much of their ADLs get so much harder. They're mentally fatigued because their brain is kind of acting up a little bit, for lack of better words. They're probably not sleeping as well, things like that. So, which can also cause more behavioral issues. It's just a whole cycle of things, I guess, adding up, I would say. So thinking about things like doing a sleep hygiene routine, working with behavioral, anything behavioral that we need to, different things like that, a toileting chart, whatever it may be that is needed just to get through that we can help with OT. And ADLs, at least in the US, we call them activities of daily living. So I don't know if that's the same for you guys in the UK, but yes, we do call them, those are our activities of daily living. So eating, sleeping, dressing, bathing, toileting, all those kind of things. Those are all considered ADLs for us.
That is the same for us, Emily, as well.
Oh, thank you. I actually have been wondering, I haven't really a whole lot of UK OTs, so I was kind of curious what I was going to hear for the same and different. So, okay, thank you. Okay, and then a team. Of course, a team is always great to work with, better than just being individual. So thinking about working with their schools, what can you do at work environments, with their families, extracurricular leaders, again, other therapies, psych, neuro. I mean, you could just go on and on about who it would be important to work with, but just making sure everybody's in the loop and really helping those patients advocate for themselves, or in cases where they need to advocate for them. But just making sure everybody's working together to make sure it works. So if you find a behavioral routine that works really great, but it's only happening in therapy, or it's only happening at home, and then there's still school problems, just making sure you're all communicating and figuring out, like, what can we do for this patient? This is working at home. How can we transfer this over? This is working in therapy. How can we transfer this into home? Because every setting is obviously going to be a little bit different. So how can we keep on making it work in other areas? So social skills, obviously, kids are going to face sometimes maybe bullying, teasing, feeling social rejection, victimization, and then insecure peer attachment risk is increased. Problems in peer relationships or difficulty making friends, stigmatism, being that kid or that person at work, and the effect that it might have on personality, all those different things that OTs can kind of help with. So social skills to help them, make and keep friends and interact, what's appropriate. They don't really have, not that they don't have, but their filter, like we talked about, is a little bit different than a filter maybe in somebody without tics or Tourette's. So helping them understand, what's appropriate and what's not, and actually learning that on a more conscious level. Whereas for some people, it may just be a little bit more natural and subconscious. Some of those coping skills, working with some of those emotions, emotional regulation, things like that. And then again, working with schools, extracurricular leaders, different things like that. And providing resources and support groups for kids or adults that may need it. Zones of regulation is really great. I don't know if you guys are super familiar with that or not, but it's a really good self-regulation tool that's really nice. It's kind of very basic and simple, but it gives you exactly what you need. It talks about, not feeling shameful for being mad or angry or really upset, but what behaviors are appropriate during that time and what are not, and how can you get back to not feeling so enraged, and different things like that, just to kind of really help with that coping. Okay, and then positional issues, we talked a little bit about this earlier, but definitely could cause, physical harm or safety issues. Sensory ladders, I haven't heard of that one. Carrie says she uses sensory ladders for self-regulation.
Sorry, yes, yeah.
Yeah, I've never heard of that. I'll have to look into it. Thank you for sharing that. But positioning wise, you know, it could have a really good effect or a really negative effect, depending on different positionings, different environments. So just things to keep in mind. Consider, like, you know, if tics are motor tics, physically, how close are we positioned to them to keep everybody safe? If they could injure themselves or others, if there's another close by, or if there's furniture or something like that close by, just to keep those kind of things in mind, keep people safe, because we can't expect 100% of the time that they're just going to not tic, and we don't want to obviously wait for that to go wrong. So things like that are important. And then considering, you know, an alternative placement in a group setting. You know, if a group setting is affecting the frequency of tics, just looking at all those different factors of how that can affect. Okay, and there's a lot more, like a lot more that could be said, but we're just about at an hour. So I'm gonna give this back over to Dr. Anderson to kind of go over some more things, some more webinars and trainings. But there's a lot of great resources out there. If you guys are still interested, I would really encourage you just to get on and look around. And we'll kind of go through some of those resources too. But I appreciate everybody's time. I'm so glad to have been able to been here today and to do this. It was really, really something I'm passionate about. So I'm grateful for the experience, and we'll be happy to take questions in just a minute.
Thanks so much, Emily. I think it's great, and we can certainly share the slides afterwards as well. And I think any of the, you know, it sounds a lot like school and any other kind of support, if it's an OT kind of support strategy that you're putting into place. I mean, obviously, we know that this varies hugely from person to person. So communicating with the person themselves, with the young person themselves, about what they feel comfortable with, what they think would be most helpful to them, I think is really great. And we know that sensory overload can be such an issue. So looking at triggers, etc., to whether, you know, their tics were particularly bad in certain situations or at certain times as well. I think we always encourage people to work with the person as well, but it's fascinating to hear from the side of the OT, you know, what you're working with with the child already, or with the person too. So we can see a whole range of different resources here, some from America, some from the NHS, also from Tourette's Action and Tourette's Alliance here as well. So that's great. I'm just going to finish off, if we can just move through the slides, to talk about a little bit more about the BTTI. I mean, I've covered already the different kinds of things that we offer. We've got the training, the masterclasses, and the clinical consultation sessions. And I think it's important also, if OTs come on the behavioural therapy training and start offering behavioural therapy, I think it's important also to know what patients and families feel. So we also run a non-clinicians workshop, so that's for parents and teachers, but anyone that's interested. And it's kind of covering what behavioural therapy is. I think often people have maybe some misunderstandings about what behavioural therapy is. If they're not, you know, if they haven't been terribly well informed, they might think that this is something that's going to sort of suppress their child or be done to their child. And actually, we know that's not the case. A lot of the therapy starts off straight away with acceptance and awareness, etc. And I'm sure that if any therapist or OT was giving behavioural therapy, or somebody came to a first session, one of the first questions they would be asking the child or the young person would be, you know, how do you feel about your tics? So are you finding them particularly bothersome or painful? And actually, if the child is saying, well, no, I'm okay, then, you know, you'd be really hard pressed to find a therapist that would push and then try and give behavioural therapy to somebody who really was quite okay with their tics. And that's absolutely fine. I think that sort of early intervention, even in those sessions, if you come across children in those sessions or in schools or in other environments where you see they have tics, I'm very much of the opinion that we should just kind of note them and go, oh, I see, you know, in a very sensitive way with the young person, but I see you have tics. Do you know what they are? Can you feel them coming on? How do you cope with them? What do people ever ask you? What do you tell them, etc.? So with BTTI, because we've got the training and the master classes, the clinical consultation sessions, we try and give that real scope so professionals feel supported in the work that they do. And then we can also reach out to the teachers and parents so that they can understand what behavioural therapy is and what it's not. You know, that a child, even if they have had experience of doing behavioural therapy, that doesn't mean that they can just have it on all the time in the classroom. That's not the case, and they choose when they can use it, for example. So I'm really excited to sort of expand this out to include occupational therapy and occupational therapists into the training as well. So I'm sure we're going to have a really interesting conversation afterwards. But let's move on to the next slide. I think we can go through these fairly quickly. So the next training, we're running them about twice a year. The next one is in September. We've got masterclasses, and these masterclasses are kind of a deep dive into particular issues around behavioural therapy for tics. So the next one is about developmental spectrums. The one in December is about comorbidities and learning disabilities and online treatment. So these are quite often issues that come up in the clinical consultation sessions. So we're listening to the clinicians and trying to create masterclasses around these issues so that we can look at them in more detail and find out how other therapists manage in those situations. So let's move on. Yeah, and those clinical consultation sessions, as I've said, it's really about improving the care of the children and young people with tics and disorders. And in those clinical consultation sessions, we also give updates. We talk about research papers that might just have come out, and that's often very useful so that we're using research evidence as a base for, well, we know that behavioural therapy works, you know, here is the evidence. There was a paper in the last sort of short while showing that homework done between behavioural therapy sessions really improve the outcomes of the person. So we think that that's important to bring that into the clinical consultation sessions. And of course, we also give little updates about events and conferences that are happening. We talk about clinical pathways and service provision, and that's a very UK focused aspect, but it comes up a lot. You know, whether the clinicians and therapists that come work with children or adults or both, and whether they work in the NHS or private or both, we cover all of those different aspects. So let's move on to the next slide. And there we go. So we're doing them every month. The last one was the 17th of May, and we have the summer off, but we're holding them every month, and we feel that that's important to have a kind of continuity of support as well. Let's move on. And there are the non-clinician workshops as well. Again, the parents and teachers and anyone who comes are very welcome to ask questions, and we look at the kind of myths and misunderstandings around understanding what behavioural therapy actually is and how it can be used at home and at school, for example. Okay, next slide. And again, we've got more signposting too. You know, it's important that people don't just get the diagnosis and then feel that there's a kind of cliff edge, you know, that there is continuing support from charities such as Tourette Syndrome in the UK. There are other smaller charities as well. And as Emily said, there is a ton of information out there, and we're really happy to signpost people towards that if you have difficulties. But there are leaflets, there are education resources, websites, videos, there are ID cards that people can apply from Tourette Syndrome and carry them around to show people if they find it difficult being out in public or in a difficult situation. They can show this to people so that they understand, you know, why they are making noises or having movements, for example. And with those associations and patient support groups, of course, there are befriending services, there are events that people can go to, there are helplines. And also, once people are trained in the behavioural therapy, whether you're an OT or a different kind of healthcare professional, there's a list of behavioural therapists that Tourette Syndrome holds, and they give that out to people who want to find behavioural therapists. And now with the advances in telehealth, of course, you could actually be receiving behavioural therapy from somebody in a different country or from the other end of the country that you're in, for example. And so anything is possible, but we know that there's a demand for behavioural therapy, that patients don't just want to be offered medication because there's no trained therapist available locally. And with the training, with the support, we're really hoping that this will sort of blossom out. We've been training hundreds of people a year so far, and that this will filter down and actually be very useful and helpful for the patients there in, say, CAMS clinics, for example, as well. Okay, great. Next. So that's myself and Emily. We're really happy to answer questions now after this presentation, and please keep in touch. I post very regularly on social media about all sorts of aspects of tics and Tourette syndrome, research papers, conferences, etc. As well as the BTTI events too. And I think the very last slide that we have, I like showing this slide. It shows two scientists talking, one saying, I've just invented a new drug for Tourette syndrome. And the second scientist saying, will it stop people with Tourette syndrome having tics? And the first scientist says, no, it's an acceptance pill for everyone else. So I think I'm very passionate, as Emily is, about behavioural therapy. We want to make sure that people understand what it is and that they have a choice, they can access it if they want to, but also acceptance and awareness, that is really the key goal. And I think there's space for all of that, all of those views and opinions as well, that you're happy living with your tics. That is fantastic. But if you would like medication or you would like behavioural therapy, that people know how to access it. And that's something that we feel really passionately about. So I'm really glad that you were able to join us. Please do contact us or follow us on the different social media channels. I'd like to thank Emily very warmly for her fantastic presentation this afternoon. And thank you again.